My name is Ulrich Stoelzel. I'm a professor of internal medicine and a gastroenterologist, and I'm coming from Germany. I'm specialized in porphyrias, and I'm the head of the largest porphyria center in Germany. The term acute hepatic porphyria refers to a group of rare genetic disorders, of which there are 4 types, and acute intermittent porphyria is the most common. Acute hepatic porphyrias are caused by well-characterized defects of individual enzymes of the hepatic heme biosynthesis pathway. Women develop symptoms more frequently than men. Acute hepatic porphyrias manifest in attacks, and typically patients with AIP have abdominal pain accompanied by constipation, nausea, and vomiting. Tachycardia and hypertension are often present, and patients can also present with neuropsychiatric symptoms, such as anxiety, confusion, and hallucinations. Real-life case of AIP involving a 24-year-old woman who presented with abdominal pain, gastrointestinal symptoms, and hyponatremia was published in Gastroenterology in 2019. The patient was admitted with generalized abdominal pain, constipation, and recurrent vomiting for 6 days. She had no history of alcohol, nicotine, or drug abuse, had a normal appearance, and was of normal weight. A physical examination revealed abdominal tenderness, reduced bowel sounds, and pain on palpitation of the upper abdomen. Pregnancy was excluded, and abdominal ultrasound showed normal findings. Laboratory analysis revealed striking hyponatremia, 117 milliequivalents per liter. The normal level is more than 133 milliequivalents per liter, and elevated urinary sodium. Brain magnetic resonance imaging, electroencephalogram, cerebrospinal fluid analysis, drug screening, and extensive laboratory tests did not reveal any pathological features. Following assessment, the patient was administered intravenous glucose and saline due to vomiting. After 4 hours, hyponatremia worsened and resulted in generalized convulsions, leading to administration of levetiracetam, sodium chloride, intubation, and mechanical ventilation for 2 days. The patient's initial diagnosis was syndrome of inadequate antidiuretic hormone secretion of unknown etiology. Subsequent interviews raised suspicion of a pre-existing eating disorder, and the patient was transferred to a psychiatry clinic. 1 month after discharge, the patient presented with epigastric colechograms, and laboratory analysis again showed severe hyponatremia, 112 milliequivalents per liter. Intravenous sodium chloride was administered with intensive monitoring. However, systolic blood pressure increased to 190 millimeter Hg. A dark reddish urine produced the suspicion of acute hepatic porphyria, and a more than tenfold increase of urine aminolevulinic acid and porphobilinogen resulted in the diagnosis of acute intermittent porphyria. The patient was treated with hemarginate for 4 days. She also received oral and intravenous nutritional support, and porphyrinogenic medications were avoided. A vicious cycling of fasting, worsening vomiting and abdominal pain, likely induced by a mild eating disorder, caused excessive induction of hepatic aminolevulinic acid synthase 1. Porphyria should be considered when a patient presents with unexplained abdominal pain and neuropsychiatric symptoms, along with other symptoms such as hyponatremia. Laboratory analysis of a spot urine sample should be used to diagnose acute hepatic porphyria, including acute intermittent porphyria.